Welcome to PWS United, a podcast for the Prader-Willi syndrome community, brought to you by PWSA USA. This podcast gives the latest news in research, advocacy, and family support by bringing together staff, volunteers, PWS treatment specialists, biotech and pharmaceutical representatives, caregivers, family members, and individuals with PWS. Our goal is to share education, awareness, and resources with those living with PWS and their supporters. Join us in our mission to enhance the quality of life and empower those affected by Prader-Willi syndrome.
Hello again. Welcome back to another episode of PWS United, the podcast for the PWS community. Today we have another United and Hope International PWS conference session recording. This session, Endocrine Issues in Teens and Adults, was presented by Dr. Diane Stafford to a live audience of conference attendees on June 28, 2025. Dr. Stafford is a pediatric endocrinologist at Stanford University School of Medicine with over 20 years of experience in the care of those with PWS. She has a particular interest in the variations in pubertal development seen in PWS. She has served as site principal investigator for several clinical trials in PWS and served as the inaugural executive committee chair of the PWS Clinical Investigation Collaborative of the Foundation for Prader-Willi Research, and continues to actively work with this group to improve the PWS community's ability to gather and examine data on the natural history of medical needs in these individuals. In this session, Dr. Stafford discusses the issues of growth and pubertal development through the preteen and teen years in those with PWS, including the effects of growth hormone therapy and sex steroids. She also discusses the indications for the use of growth hormone therapy in those who have completed their growth, including risks and possible benefits, and the indications for ongoing sex steroid therapy in adults with PWS. In this discussion, you will learn more about growth hormone monitoring and deficiency, delayed or absent puberty, adrenarche versus puberty, and more. And as the mother of a 13-year-old with PWS, I was very interested in the information this session offered. So a few things to note. One, Dr. Stafford accompanied her presentation with some slides, but the information is still attainable to podcast listeners even in the moments when she does reference those slides. Another important thing to note, and this is something we will improve upon for next time, but we did not have a podcast mic for questions from the audience, nor did we ask Dr. Stafford to repeat the questions. So unfortunately, I could not decipher the questions in the edit enough to add them in post-recording. If you listened to the recorded session with Michael Tan on nutrition, you would have heard where I was able to do that. However, with the complexities of endocrinology and the personal details to many of the questions, I just wasn't able to confidently recreate the questions. So I tried a thing, okay? So in the recording, when someone asks a question, I just sped up the audio. I promise you wouldn't have understood what was said. But I did this to signify that there was a question asked. And Dr. Stafford's responses are still in the recording as they contain valuable information. And I believe that if the information applies to you and your loved one, you will understand the response. So I don't think the question is necessarily crucial to the information, to the answer that she provides. And I hope that you all find that as well. Okay, I do apologize for the lack of sound quality for audience questions. And again, this is something that we will remedy in the future. But with that, we would like to thank Dr. Stafford for her willingness to let us record the session and for her knowledge and her expertise and her commitment to our PWS community. We are so grateful. Now, here she is from the United and Hope 2025 conference podium.
Thank you. So I talk about PWS quite a lot. My children say, if you just push a button, mom starts talking about PWS. But I have to say this particular talk is totally in my happy place with talking about PWS, which in particular is talking about PWS in teens. and young adults and really thinking about the endocrine issues that they face. I think in particular, some of the issues we'll talk about are things that we don't talk about very much in the community because there's a lot of other things to talk about. But these are really important factors in the health of children and young adults with PWS. So hopefully I can do it justice in the period of time that we have. I will say I did not pack this with slides in the hopes that this can be a lot more interactive. So we will certainly have time for questions at the end, but I am perfectly open to raised hands and questions during the talk, particularly if something that I'm saying is unclear. Endocrinology is, to me, intuitively obvious, but not so much to other people. So hopefully we can go through this together, but please feel free to interrupt me if what I'm saying isn't clear. Okay. I should also say that many people still think that I live in Boston. I lived in Boston for a very long time. I was at Boston Children's for 22 years, but I've now been at Stanford for about 7. And it's always fun when I come to these things to see families that I used to take care of in Boston, as well as the families that I now take care of in California. So first of all, everybody has a conflict of interest. Mine are almost all PWS clinical trials related, but I am a PI for the upcoming Aardvark study, the HERO study. I'm PI. I was co-PI for Compass PWS, or I am PI for Compass PWS for Acadia. I was co-PI for Soleno's Destiny PWS trial, and I'm a PI for the VNS for PWS study. So what are we going to do today? What I hope to do is to help you to understand the effects of growth hormone therapy, both in growing children, but also in those who have completed their longitudinal growth, to understand the variations in the timing of puberty in those with PWS and the possible need for hormonal supplementation, to understand the risk factors for decreased bone density in those with PWS, to gain a better understanding of the possible effects of anti-obesity medications in PWS, and then really to think about the routine monitoring for medical issues associated with older children and adolescents and young adults with PWS. So starting to talk about just PWS in adolescence and young adulthood, what do we see? One of the things we know is that historically, average heights for those with PWS as adults was significantly shorter than the normal population. So about 155 centimeters for males, about 147 centimeters for females, so without growth hormone. So that's the historical perspective. That is the result of several different issues from an endocrine point of view. One is growth hormone deficiency, which is somewhere between 30 and 80% of the population, depending, which is a big spread, but it depends on how you define it and how you test for it. But clearly there are issues with growth hormone, either production or release in PWS. There is either delayed or absent puberty in PWS, which affects growth as well as other factors. There is normal or early adrenarche, which is the development of body hair and body odor in PWS that can also affect growth. There is a continued risk for obesity through adolescence and young adulthood due to hyperphagia and dietary issues. And then there's an increased risk for complications resulting from obesity, including type 2 diabetes, obstructive sleep apnea, and hypertension and other cardiovascular risks. There's continued behavioral issues with hyperphagia through this period of time. And then there's ongoing medical needs that are related to both PWS and the natural aging that we all do, and issues of transitions to independent living. I'm not going to talk a lot about transitions today, particularly with regard to independent living, but just so we all understand that all of the medical things that we are talking about in PWS affect the ability of those with PWS to transition to independent living. So starting with growth hormone therapy, there are varying benefits. There are a lot of benefits of growth hormone therapy in PWS. The first is an improvement in longitudinal growth, and that was actually the initial approval for PWS was based on short stature and an improvement in longitudinal growth. What we all understand in the community, and fortunately what is becoming more clear to insurance payers and other people, is that there are a lot of other advantages of growth hormone therapy. There are improvements in body composition with higher muscle mass and lower fat mass. There's an increase in energy levels and just physical ability to engage, the ability to engage in physical activity. There's improvement in strength and agility and endurance. And there's most important, particularly in our younger patients, is the increase in respiratory muscle force, which allows for actually improvements quite frequently in the obstructive sleep apnea that we see. But also in older children, the ability to breathe deeper and better is also going to affect their respiratory function. So the difficulties, most people with PWS are on growth hormone while they are growing. And the difficulty becomes, what do we do when those with PWS have completed their longitudinal growth? Unfortunately, because the initial indication for growth hormone therapy was for growth and not for all the other advantages that we as a community see with growth hormone therapy, there is no current FDA approval or indication for growth hormone therapy for the diagnosis of PWS. And that leads us to the difficulty of having to diagnose those with PWS with growth hormone deficiency in order to allow them to stay on growth hormone. In my experience, this is highly variable with respect to when that point in time actually occurs. Some insurers, once you get to a particular age, will say, prove to me that this patient is still growing. Some will kind of turn their back and ignore it until people get to 17 or 18. There's just a high degree of variability. My own experience has been that I have to cope with this on basically a patient-by-patient basis. That when we're at the point where an insurer is saying you no longer qualify for growth hormone therapy, how do I look at that particular patient and decide how to make an argument that people hear me say this all the time. If it looks like a duck and walks like a duck, it's duck. How do I get them to see that a diagnosis of growth hormone deficiency made complete sense for this particular patient in front of me? And so what are the difficulties with that? It frequently requires discontinuation of therapy for some period of time. Many of those with PWS have low normal IGF-1 levels. So they're not complete. They don't fall into the, oh yes, of course, that patient is growth hormone deficient category. They're in this endocrine gray zone of low, but not blatantly abnormal. And growth hormone stimulation testing, which for many insurers is the gold standard. It's a bad gold standard, by the way, but that's a whole nother lecture, is the gold standard. Many patients with PWS will pass a growth hormone stimulation test because their problems are not at the level of their pituitary gland, which is what those tests are designed to look at, but but higher than that, at the level of the hypothalamic control of growth hormone. So we always have this problem. I will tell you, I have done a variety of things. I have done DEXA scans with people on growth hormone, taken them off growth hormone and repeated their DEXA scan a year later and shown that their lean body mass decreases, their fat mass increases. And again, they have a low normal IGF-1 level. And if it looks like a duck and walks like a duck, it's duck. I have made the argument that they have multiple pituitary hormone deficiencies. So that includes disorders of puberty. It includes thyroid dysfunction, and anything that says that the pituitary is not working as well as it normally should can be an argument. And multiple pituitary hormone deficiencies is a good argument for growth hormone deficiency. So what I would say about growth hormone in adulthood is that if you want to make the argument, you have to make it on an individual basis. Because there is no indication. So talking to your endocrinologist about how you collectively can test for, do whatever you can to try to make that argument. The other thing that I've started to do, even though I'm starting children quite young, is to actually look at their IGF-1 before we start growth hormone therapy, so that eventually maybe I can use that as one of my criteria, even though it's probably 18 years later, use that as one of my criteria. So I should say, though, that there are also concerns that have been raised about the long-term safety of growth hormone in adults, and particularly the impact on glucose metabolism. Data from non-PWS growth hormone deficient adults would say that with appropriate dosing, which the adult dosing is different from the pediatric dosing, that replacement therapy with appropriate dosing and appropriate monitoring isn't really causing huge amounts of, or any increased rates of cancers, solid tumors, all of those kinds of things. Glucose metabolism is always, in my mind, a push-pull. that, yes, growth hormone can affect glucose metabolism, but I'd rather have somebody on growth hormone and deal with their issues with glucose metabolism than not have them on growth hormone and still have glucose metabolism issues. So again, I think we as endocrinologists need to think about risk benefit analysis for that particular patient, and what do we think are the advantages? How are the advantages and disadvantages of growth hormone therapy weighed for that particular patient? So what are the benefits in adulthood? I'm sorry, go ahead. The data on glucose metabolism with ViCat. I don't want to go too far down this because I want to make sure we're keeping track of time. But the data on glucose metabolism in ViCat is that it may change hemoglobin A1C and fasting blood glucose a little bit. My own view is that I am not restricting the use of ViCat for somebody who may have marginal glucose metabolism. I'm just watching them. And I'm watching them closely. And I'm looking at what the advantage of ViCat is to them over the advantage of not being on it, and then deciding whether, if their glucose metabolism is changing enough that they might need therapy, what are again, just like with growth hormone, what are the risks and benefits of leaving them on a drug that might be helping with one aspect and treating another aspect, right? So I don't think that we should think of it as exclusionary. I think because the data is, we're going to find out when we treat more people what actually is happening in terms of glucose metabolism with ViCat. But I don't feel like, I think for most people, while it may change things a little bit, it probably won't change things that it pushes them over the edge to needing therapy as much as it does as much as the advantage to ViCat may have with hyperphagia and therefore weight and therefore glucose metabolism, that it may actually work itself out in the end. But knowing that it's a risk means we have to monitor. And I feel the same way about growth hormone in adults. I think in kids, we have enough experience that as long as we're not pushing dosing too high, such that it's sort of super physiologic and might affect glucose metabolism, that we're probably doing okay. And the benefits in general outweigh the potential downside from a glucose metabolism point of view. So I hope that is at least the quick answer to the question. Yeah, I think we have to watch and learn. I think that's going to be the case with all of these drugs. We have to watch and learn, right? Doing a clinical trial is great, gives you a lot of information, but getting a drug out and really looking at it in a real world setting tells you more about what you really need to know, what we need to know as prescribers, and what families need to know as users of those drugs. So most of the data that we have on the benefit of growth hormone in adulthood comes from Europe. And that is largely because there's no indication in the US, and therefore it's very hard to track what's really going on. There was a study done in 2021, or actually an advisory board for IPWSO that looked at that tried to gather all the data about growth hormone treatment in adults. And what they found in looking at all the literature was that discontinuation at completion of growth can result in a deterioration of body composition and a change in metabolic markers, lipid profiles, other things that are affected by growth hormone, and that the effects in transition to adulthood and in adults are a reduction in body fat and an increase in lean body mass, improvements in physical performance and psychosocial functioning, which is also what you see in non-PWS adults with growth hormone deficiency when they stay on it as adults no longer growing. Improves physical fitness because of ability to exercise, improved cardiovascular risk markers, and improved quality of life. Every time I talk to a growth hormone company, I tell them how we really need a study of adult growth hormone therapy in PWS, and wouldn't anybody love to do that? I'm like the broken record. They don't call me much anymore because they keep hearing the same thing from me. But, I think as companies start to look to expand markets and do other things, I'm certainly hopeful that somebody may bite at some point on actually doing a study. It's a little hard to look at the effectiveness of growth hormone in non-growing people But I think we can use the approval for adult growth hormone deficiency and the methods for doing that as a way to look at this. But obviously, when you're testing growth hormone in growing children, what you look at is, do you change their growth trajectory? And in this case, we have much softer and much less obviously quantifiable differences. So I want to turn to what is honestly my favorite topic ever all the time, which is puberty, and talk about adrenarche versus puberty in PWS.
Yes.
Yeah. And there's another question back there. So is it DEXA or bone age? And this is where you get to the difference in the way we actually look at growth. So bone age is, are you still growing? Right. And so it may be that the reason that they're saying we'll stop at NCE is because bone age has actually, she's reached the point where she's no longer physically growing, that her bone age is 17, right? I do think that this is the point. This is where you get to, can you actually keep her on growth hormone? And so this is where you have to actually make the argument, try to make the argument. And honestly, sometimes you can and sometimes you can't, that she has growth hormone deficiency. So thinking about, does she have other hormonal deficiencies? What happens to her IGF-1 when she actually comes off of therapy, right? If she started beforehand, it may be that there's reason to think that she actually has growth hormone deficiency and was then diagnosed with PWS. I mean, this is where getting to the individual basis of that diagnosis, I think, is really, really important. And talking about, can we make the argument that this individual patient has growth hormone deficiency? If that makes sense. And I can't, without knowing a whole lot more, I can't tell you how I might make that argument. But I think if she's finished growing, if her bone age says she's finished growing, you sort of don't have a choice but to take some time off and then look at IGF-1 and try and BP3 and try to make an argument that there's growth hormone deficiency in order to put her back on. Yeah. It's really hard for me to say without knowing how big she is. You can dose, a lot of people dose at that age on body surface area rather than on weight. I do a lot of IGF-1 based dosing, so I want to keep IGF-1s in sort of the upper quartile of the normal range. So there's lots of different ways to think about that dosing. And without knowing more, I can't say, 1.8 is really, really, I have to look at it in context and knowing what her IGF-1 is on that therapy as well. Okay. Yeah, I do think that I can't say about specific insurers because honestly, I get intermittently fought by all of them. I do think that most state Medicaids are a little more permissive. I think part of that is that the larger insurance companies have people who they pay to say, do you check all of these boxes? Right. And if you don't check all of those boxes, the answer is no. I think most state Medicaids do not have people sitting around checking those boxes. And so they're much more willing to say, gee, there's a professional who knows something who wants to prescribe this drug, right? Not to say that they don't occasionally say, give me a good reason, but I do think there's less of that. Now, honestly, how things are going to change, my crystal ball just is not working right now. And so I have no idea what's going to happen in the future. There was another question? Yeah, so the dosage guidelines for adults are very different. The doses are significantly lower. And the IGF-1 values that you're trying to get to are significantly lower. The indications for, the dosing for adult growth hormone therapy actually starts very, very low and works up. I have generally not been starting from the beginning with my patients with PWS, but cutting their dose and then looking at their IGF-1 levels. I haven't had too many insurers who are willing to cover it say, that dose is too high, if I can show them an IGF-1 level that's within the normal range for age. Okay, so I think maybe we're back to where we were going to be. All of this I pretty much talked through, but there is a reference here to this opinion from 2021. Let's first talk about puberty and adrenarche. Okay, most people think of puberty as being one big thing, right? You get express in girls, you get breast development, body hair, body odor, growth, all of those things together. In boys, you get body hair, body odor, penile enlargement, testicular enlargement, all of those things together. The system is actually a little bit different from that. And we as endocrinologists see a lot of the times where there is asynchronous development of parts of those systems. In fact, there are secondary sexual characteristics are driven by these two separate forces, these two separate cascades. One of them is adrenarche, which is the maturation of the adrenal gland and the production of androgens, both in boys and girls, that gives you, in male hormones, androgens, that gives you pubic hair, axillary hair, and body odor. So that's true in both boys and girls. In boys, eventually puberty and testicular production of those androgens takes over. But in all girls, most of their androgens actually come from their adrenal gland, not from the ovary. There's some production by the ovary, but the majority of it is adrenal. Then you have what we as endocrinologists term true puberty, which is activation of what we call the hypothalamic pituitary gonadal axis and the production of estrogen or testosterone by ovaries or testes. And that actually gives you, in girls, breast development, and in boys, an increase in testicular size and then genital changes that go along with testosterone production. And the reason I spend a lot of time both with you and frankly anybody else who will listen, distinguishing between these two is that when you have abnormalities of one or the other, you need to say, is this adrenal or is this gonadal, right? Is this ovary and testes or is this the adrenal gland? So what we know is that in PWS, am I changing now? Okay. It'll teach me not to watch the slides back there. There is a reported increase in incidence of what we term premature adrenarche in patients with PWS. And that is defined as the development of body hair and body odor before 8 years of age. There are studies that have shown increases in the incidence of adrenarche with increased adrenal androgen levels, including what we call DHEAS and 17-hydroxyprogesterone, when compared to obese controls. And the reason that's important is that we see a lot of premature adrenarche in people who are obese. In PWS, we see premature adrenarche whether you are obese or not. So there's an increase in adrenarche across the board. The etiologies may be related to being small for gestational age or some kind of IUGR, because we see that as well. It may be hypothalamic abnormalities like everything else. By the way, when you see an endocrinologist start doing this is called endocrine hand waving. It means we don't actually know what causes something. Okay? And so we go, well, maybe. Yes. So it's called endocrine hand waving, and we all do it. So at some point, so it may be hypothalamic abnormalities. It may be the effects of obesity or some combination of all of these things. So what do we know about premature pubarche or early development of body hair and body odor in children with PWS? There was a Dutch study of 120 children aged, with a wide age range, that showed that DHEAS levels, which are one of the hallmarks of adrenal steroid production, adrenal androgen production, were higher even in 3 to 6 year olds, indicating an earlier onset of adrenarche or that adrenal activity. That the incidence of premature pubarche in their study was about 30% in girls and about 16% in boys. And in the general population, premature adrenarche that's associated with obesity is actually seen more in girls than in boys. So there's something different about those two. But that in their study, there was no difference in weight SDS, in BMI SDS, in duration of growth hormone treatment, in genetic subtype, that there aren't the usual things that you might think are cues that maybe somebody's going to develop premature adrenarche. It just seems to happen. And again, endocrine hand wave. DHEAS levels were higher in children with PWS, but not higher than the adult standards later on, which means they don't have an intrinsic problem with their adrenal gland. They just have sort of early activation of adrenal steroid production. And then this study was actually done from data from my cohort of patients with PWS at Boston Children's Hospital, looking at males and females and looking at comparing DHEAS levels in these patients over age to sort of healthy age-matched controls. And what you see is that the DHEAS levels, all the black, are the PWS patients, and the DHEAS levels in them are significantly higher. And the mean age for Tanner 2 pubic hair, meaning that sparse little amount of pubic hair around the genitalia or possibly under the arms, was about 8.8 years in males and about 7.3 years in females, which is not dramatically earlier, but certainly earlier than average for the population. So we know this is really, really common in PWS. In general, I don't look at DHEA. I've been doing this long enough. Like unless somebody's progressing really quickly, or I'm worried about excess androgens for other reasons, I'm not routinely checking DHEAS levels anymore. Although clearly I was, because that's where this data came from. I think if I'm worried, I do. But in general, this is really, really common. And this has been described for a very long time in PWS. So when you see those little bits of hair at, 6 or 7, point it out to your endocrinologist and make sure they're not worried. But most of the time, this is actually very normal. So what about puberty in PWS? So puberty in PWS is characterized by hypogonadism in both early and late childhood. And the interesting thing about this is that in the newborn period, we see a lot of cryptorchidism, undescended testes in boys, 75 to 95%, really very, very high. And that descent of the testes is dependent on the ability to make testosterone. Right. So the thought is that inability to sort of regulate that hypothalamic pituitary gonadal axis is present in utero with lower levels of testosterone production that lead to this cryptorchidism. And small labia minora, which is less obvious to people than your testes aren't where they're supposed to be, but probably in about 90%. If you look at testosterone, estrogen, and gonadotropin levels, they actually look kind of normal. But it's a little hard to know whether measuring them, the standards for what's normal is a little odd in this age group. There's actually a group of people through CLIC who are trying to look at what's called mini puberty, which is the normal rise in these hormones, either at birth or at about 6 to 8 weeks of age. And so in PWS, and actually try and look at what's happening at the level of the hypothalamus and the pituitary and the gonad in that newborn period. So more to come on that. In adolescence, this hypogonadism can lead to delayed puberty. It can lead to entrance into puberty, but lack of progression. And it can lead to early or actually precocious puberty sometimes, that there's just a dysfunction at the level in this control system that can lead to a whole spectrum of issues. I should say this is actually how I got into taking care of patients with PWS to begin, is because of my interest in variations in the timing of puberty. There are 2 studies that have looked at hypothalamic pituitary gonadal axis function in males. There have actually been others. But the interesting thing about this, without sort of belaboring the point, is that we as endocrinologists classify hypogonadism usually into what we term hypogonadotropic hypogonadism, which is a lack of the ability of the hypothalamus and the pituitary to switch on and therefore produce estrogen and testosterone, or hypergonadotropic hypogonadism. Don't you love endocrinology? Where those signals are made by the brain, but the ovary or the testis are unable to respond. Right? So we think of it as you're either hyper or hypo. In PWS, you're kind of met. You're kind of somewhere in between. And what we think is that looking at it, it looks like there's a combination of hypothalamic dysfunction with luteinizing hormone, or LH, being relatively low, measurable, but relatively low, and primary gonadal dysfunction with markers of gonadal function, inhibin and FSH, being more indicative of that gonadal dysfunction. So what this means from a practical point of view is that, again, you need to look at the patient in front of you and not so much at the numbers, but are they progressing? What's actually happening with that particular patient? Because if you look just at LH and FSH and inhibin, you get this meh of, yeah, maybe not. So you really need to look at the person in front of you. In terms of girls, there was a study that looked at 45 girls with PWS. Most had incomplete sexual development as adults. There was about a 25% rate of hypogonadotropic hypogonadism, meaning The switch didn't look like it had turned on at the brain, but most of the time, again, they had a combination of what looked like a primary gonadal defect and hypothalamic dysfunction, similar to that seen in boys. There are patients who have spontaneous menses with PWS, but they will eventually develop either oligomenorrhea, meaning irregular menses, or amenorrhea, meaning their menses will actually stop. So again, multiple causes. There are genes on the long arm of chromosome 15 in primates that play a role in spermatogenesis and may cause testicular dysfunction. It's been hypothesized that loss of nectin may result in impaired GnRH neurons, the hypothalamic neurons that trigger the system and contribute to the hypogonadotropic hypogonadism. There are no reports of spontaneous fertility in males that I'm aware of, although there are a few spontaneous pregnancies in females with PWS. So why do we care, right? Really, it's not about boobs. It's not about facial hair. It's not about any of those things. It's about the effects of androgens and estrogen on the body. So without testosterone or estrogen, you have impaired growth. You don't get that pubertal growth spurt that is dependent on not just growth hormone, but also on the presence of estrogen or testosterone. Bone density improves with sex steroids, so you're at risk for lower bone density. There are positive impacts on lipid metabolism. There are improvements in the ability to build muscle mass and the psychosocial impacts of secondary sexual characteristics. I have several patients who come in who've said, everybody else, particularly girls, everybody else is developing boobs and I'm not, right? And so that there are already enough differences for children with PWS, let alone also saying, and you're going to look like you're 9 for forever. So how do we think about the timing of sex steroid therapy? I really think about this. I sound like a broken record. I do this on an individual basis. I look at, do they have a complete lack of spontaneous progression into puberty at an age when I would expect, or at a bone age when I would expect, right? Which is somewhere in the range of about 10 or 11 for girls and about 12 to 13 for boys, okay? What's their pattern of growth? Are they slowing down in their growth despite being on growth hormone in a way that might imply that they're going to need sex steroids in order to improve their longitudinal growth? I have a lot of discussions with families, and I start discussing it before their pubertal age, right? In a year or two, we're going to have to make a decision about whether or not we need to start sex steroids, because the sooner we start that conversation, the better the conversation is and the better our decision making is in the long run. I sometimes will do bone density evaluation. I don't tend to do them except in older kids where I really think that there might be a benefit, but families have hesitation. That if we can get one other piece of data that says that there would be a physiologic advantage to therapy, I sometimes use bone density. I always start with low doses and work my way up, because what I want to do is mimic the normal increase in either testosterone or estrogen that the body would normally be seeing. I do that both because that's what should happen. That's what I do in my patients without PWS who have hypogonadism, as I start low and work my way up. And it also optimizes growth. If you give somebody a large dose of testosterone or estrogen, you may get them growing for a while, but you're going to actually fuse their bones, because that's what estrogen and testosterone do in the long run. None of us are growing because we all have fused our bones. And then I also always have conversations about concerns about behavioral change. I'm going to show you a couple of growth charts and then I'm going to move on. But mostly what I wanted to show you is, it's lifelong. Yeah. So reasons to discontinue are really lack of tolerability of it. Although I think there was actually a really great talk Thursday. I'm losing track of days, that actually looked at tolerability, particularly of testosterone with respect to behavioral aspects and that kind of stuff. And there are very few issues. Sorry? So in females, the biggest reason why people want to stop is concerns about menses and menstrual management. There are a host of ways to do that don't involve not giving people estrogen. right? So you can put people on continuous estrogen and progesterone and have them have withdrawal every 3 months, every 6 months, not at all. There are lots of different ways to do it. But you build bone mass until you're in your mid-20s. So that's really, in my mind, the prime time that you want to make sure that people are seeing enough estrogen and testosterone is while you're building bone mass. And then you're going to work off that until you're 90. So you're preventing osteoporosis in the long term. But ideally, people would just stay on. Yep. No, it's not. It's nothing beyond. No. It's just people, people with PWS aren't necessarily great at their own hygiene, right? So I hear a lot of laughing. Yeah, we get that. So menstrual management becomes a practical consideration. Yeah. I'm going to show you a couple of growth charts really fast. So this is what happens with somebody who is growing normally. And then just kind of, you can see before the arrow, there's like this flat growth chart, right? There's no growth. And then starting estrogen actually gets that patient growing better again. The same thing is true. This is actually one of those, wow, I learned something from this patient. This is somebody who I took care of in Boston who looked like she was progressing through puberty. And so I did not put her on estrogen. And what happened was she had this growth spurt and then she stopped growing. So she didn't have a complete growth spurt because she was making some estrogen. She was making enough estrogen to age her bones, but not enough estrogen to give her a really actually substantially normal growth spurt. But this is where you get to, you need both, and you need an appropriate amount of both. This is one of my patients who was quite small, wasn't going through puberty, and at 14 we started her on Vivel, which is my drug of choice for estrogen replacement. And you can see how her growth improved. We then changed her over to adult dosing when she's about 16, but she actually got a substantial amount of growth. And yes, she was on growth hormone. Almost all my patients are on growth hormone. So these are the effects of testosterone and estrogen in the longer term. So, eventually, yeah, I would recommend that we look at what her growth is like, what her bone age is, what her physical exam looks like, what her estrogen level looks like, right? So, but the majority of my patients, I do have a few who are not on therapy because they're actually having oligomenorrhea, but they have enough menses to tell me that they have intermittent menses enough to tell me that they're probably seeing enough estrogen, right? So, but people who are either not progressing or not having regular menses and don't respond to progesterone, like don't respond as if they're making enough estrogen, I think should be on estrogen. So, one second. For growth, probably. If he's 22, his bone age is probably over 17 and he's probably not going to grow anymore, but not for bone mass, not for muscle mass, not for lipid profiles, not for the other things. So, but in that case, you need to look at his testosterone level, right? So typically what I see is in patients who are coming to me around that age is that they have measurable testosterone levels. They're just like in that they're meh. They're 150 when adult norm is over 300, right? And so I don't try to get them, normal is 700 plus or minus 400, right? I don't try to get them to 1100. I try to get them to 300 or 400, right? To what their body needs. So it's not unusual to see testosterone levels, but relatively low testosterone levels. So the pictures I just showed you were all girls, but I have examples of that in boys as well. And we see it, I mean, I think from an endocrine point of view, it's important to give you the context, which is that in patients, for instance, who've had brain tumors, who don't make growth hormone or testosterone, when we just give them growth hormone, eventually they grow slower until we give them sex steroids as well. And then they start to grow better, that there's a synergistic effect. And it's not just that testosterone increases your secretion of growth hormone. There's direct effects of testosterone and estrogen on bone growth that you do not get if you're not using them synergistically through that period of time, right? Yeah, let me blow through the rest of this just so I've said it. I tend to use for girls, I tend to use transcutaneous estrogen. Vivel is the brand name, but there's a couple of different but there are generics starting at low dose and increasing slowly. I do that so I'm not shocking the system with testosterone, but also that if there with estrogen, but also if there's an advantage in terms of growth, I want to mimic what the body would normally be doing in terms of that production. Typically, we add oral progesterone after an initial menstrual bleeding. You do need testosterone. You do need estrogen and progesterone to protect the endometrial lining from things like endometrial cancer and things like that. You need to shed that lining intermittently, or you need to have both estrogen and progesterone. When you get to the point where people are through growing and you're giving them therapy, there are a whole lot of, I could fill 6 slides with the various ways of doing that. You can give birth control pills. You can continue to use transdermals. You can use a transdermal estrogen and a progesterone IUD. You can no. There are a whole lot of ways to do it. And that becomes very individual. For boys, my personal choice is either intramuscular or subcutaneous testosterone, starting at low doses and slowly increasing. I have a lot of concerns about using testosterone gels in patients with PWS, or for that matter, for adolescent boys more generally, because it's really, really easy for testosterone gels to end up on other people. And I'm just paranoid because I don't think testosterone should end up on other people. I think it should stay on the person for whom it was prescribed. So I used to use testosterone patches because there was less potential for that, but those are now off the market, so you can't do that anymore. There is now an oral testosterone, but it's really not, the dosing is such that it hasn't been tested in induction of puberty. So I do sometimes use it once people have gotten to where I want them from an adult point of view. But the goal, again, is sort of low normal adult testosterone levels, give them the advantage, all the advantages we can without overdosing them or having parents be worried about behavioral change. A little bit about bone density in PWS. I just was saying that testosterone and estrogen are really important for bone density. That is definitely true. People with PWS, in addition to their hypogonadism, also have an underlying risk of low bone density because of hypotonia and because of obesity. So when you combine all of these things, bone density, long-term bone density is definitely a risk. Various meta-analysis looking at patients with PWS have shown a prevalence of osteopenia, osteoporosis for anywhere from 2 to 26%, depending on how they actually ran the study. I think most people think that's probably an underestimate. Osteoporosis is more common in males than in females, which may be a function of when we actually recognize the need for sex steroids in them. But again, it's a little hard to know looking at sort of a meta-analysis. And the use of psychotropic medications is also associated with a decrease in bone mineral density. So all of these things put our family members with PWS at risk. In terms of what can we do to prevent low bone density, we can optimize vitamin D. So making sure that everybody's getting appropriate vitamin D supplementation somewhere in the 800 to 1,000 international units a day. Vitamin D deficiency is really common in the general population because nobody spends enough time out in the sun without sunscreen on, and nobody gets enough from their diet. So 30 minutes of exercise a day, so weight-bearing exercise is actually a really good way to build bone mineral density, optimizing sex steroid replacement, and then awareness of the risk of fractures and the high pain threshold that our kids and young adults with PWS have. That if they start complaining of a little bit of back pain, it's probably worth paying attention to that. They do have scoliosis, they do have other things, but they can also, particularly as they age, develop compression fractures that may actually be clinically significant. In adults, the recommendations are for DEXA scans in adulthood about every 5 years, if normal, and yearly vitamin D levels for screening. I'm going to skip the next couple of things, which are basically just talking about comorbidities. Type 2 diabetes is more common as children with PWS age. The other thing is that risks for complications of diabetes seem to be higher in patients with PWS than they are in the general type 2 diabetes population. So trying to be fairly aggressive about how we evaluate that. Cardiovascular disease, again, associated, and these are old data, so it's hard to know, like with as the current population who's on growth hormone, who's had behavioral controls that are decreasing, obesity, a few other things, how these play themselves out. But in general, there's an increase in prevalence of cardiovascular disease with age, an increase in hypertension with age compared to the non-PWS population, an increase in sleep apnea compared to the general population. Knowing that the very early data here are probably related to coding for sleep apnea, so that we can make sure everybody has a sleep study when they go on growth hormone, et cetera. So I think this data is skewed at the young age because of issues of wanting to establish whether people actually have diagnoses of sleep apnea before starting growth hormone. And then this is a very nice review article from quite a while ago. And it's really small, and I'm not going to go through all the details, but there is a lot of evidence that multidisciplinary care continues to be required for those with PWS into adolescence and young adulthood. And, there's a series of recommendations in terms of things that are related to PWS, but also things that aren't related to PWS. Seeing a dermatologist, making sure you're not developing skin cancers or other things as you get older. But more importantly, continuing to look at thyroid function, at growth factors, at hemoglobin A1C, at calcium, CBC, sort of general health, as well as nutrition, as well as orthopedics, and all of the various specialists that many people see as children. They also need to continue to see as adolescents and young adults. There's I have a few slides on anti-obesity medications in PWS. I'm going to skip that in favor of some more conversation. But that is to say that there's not great data that any of the GLP-1s, that topiramate, that any of the current drugs that are used typically as anti-obesity drugs work particularly well in PWS, which is why we're working so hard to try and find other things that will be helpful for our population and the people that we love. So I'm going to stop talking and answer a few more questions. Yes.
So one is Middle Ashley has fine.
Does she have regular periods off birth control? So if you're having regular periods, that is your body telling you you're making sufficient estrogen, right? So I will usually not. There are a couple of reasons to go on birth control. One is estrogen replacement. One is predictable periods, right? If it's working, there's no particular reason to think that that she should be off them. But if you wanted to run the experiment and say, what do her periods look like off birth control? I don't think that's an unreasonable thing to do. Not everybody needs to be on birth control. If you're having regular periods, it is a marker for your body that you're actually making sufficient estrogen, that you don't need it as estrogen replacement, but you may need it as regulation to make sure that you're not like waiting for the other shoe to fall for her next period all the time.
So I should do the experiment.
I think it's up to you whether you want to run that experiment, but you certainly can.
What's the difference in physiology?
Yeah, it's a really, really good question. I will say that if you talk to 8 endocrinologists, you probably get 8 different opinions. This is, again, endocrine hand waving. I think that there's a lot of people who believes, and I think there's good reason to say, that transdermal estrogen is more physiologic. It doesn't have to go through the liver and be metabolized. It, goes straight into the system. You can actually measure estrogen levels in the blood related to beta estradiol, which is what's in the path. The biggest problem with that from a functional point of view is you need progesterone 5 to 10 days, 5 milligrams, 10 milligrams, Prometrium, Provera, a million different ways to do that. But you need to have a period of time where you get progesterone and then you stop the progesterone and have a menstrual period, right? Shed that endometrial lining. For many people, remembering to do the Provera is a huge problem, right? And you have to change the patches twice a week. It takes organizational skill. And sometimes people have enough things they're trying to organize. All right. So I frequently will say, if people come in and say, yeah, I'm never remembering to give that, or I keep forgetting to change the 5L patch or whatever that is, I'll say, you know what? it's probably, there may be a little bit of trade-off. The reason, so people like Vivell because it's physiologic. There's also a small amount of data that it may be better for bone density than birth control pills as a replacement. However, I don't think that you should make perfection the enemy of the good. If you're never going to remember to give the Provera and to change the Vivell, you should go on an OCP. You give it every day, right? And you give it all the time, and you can decide, using birth control as a estrogen replacement is a perfectly reasonable thing to do if it's going to be a better way for you to actually manage to get estrogen into the patient than Vivell, even if there are trade-offs, even if there are potential trade-offs, not even definitive trade-offs, but potential trade-offs on bone density or other things. So really, again, it comes down to the individual decision. We should all be talking to our patients. You should be talking to your doctors and saying, this is working, this is not working. What are my other options?
So first of all, thank you, because clearly
Thank you for listening to this episode of PWS United. If you want to learn more about Prader-Willi syndrome and how PWSA USA is making strides in advocacy, family support, and research, visit www.pwsausa.org. And while you're there, we encourage you to sign up for our Pulse email newsletter to stay informed about the latest news, resources, and events. Don't forget to subscribe to the PWS United podcast so you never miss an episode. Our team is always available to support families and their loved ones living with PWS 24 hours a day, 365 days a year. You can call us at 941-312-0400 or email info@pwsausa.org. Catch a new episode next Tuesday, and until then, have a great week.